Welcome to the deep dive. We're here to break down complex info, make it clear, and really give you the essential insights.
That's the plan.
Today, we're taking a journey, a really important one, into human physiology. We'll be looking at how the body works and, well, sometimes how it doesn't, using real clinical cases.
hmm
Our guide is Vander's Human Physiology, the 16th edition, and our goal is to show you how all these body systems connect, especially when things go wrong. We'll explain the technical bits simply so you can follow along easily.
Exactly. And what we're really focusing on here is integrative physiology. It highlights how these complex cases, they almost never involve just one single organ system.
Right, it's all connected.
It really is. It's about seeing those connections, understanding not just what's happened, but why it matters, and how it all relates back to the body's constant push for homeostasis, balance.
So basically the core principles behind health, but without getting lost in the jargon.
That's it, making it accessible for you.
Okay, let's jump into our first case study then. We have a 33-year-old woman. She comes in, and for about a year, she's been feeling more and more nervous, irritable.
Right.
She's also noticed her heart pounding palpitations, as doctors call it. But here's where it gets really interesting. She feels hot, like too warm, even when others are comfortable.
Heat intolerance.
Exactly. Her skin is warm, moist, and get this, she's lost 30 pounds. 30, even though she's eating more than usual.
Wow, yeah. Voracious appetite, but weight loss. That's a
Yeah.
big clue.
And there's more. Muscle weakness, mood swings, her periods are infrequent, and she even has double vision sometimes, especially when looking sideways. It's quite a list.
It absolutely is. And what's fascinating is how these symptoms, which seem maybe unrelated at first, start, paint a picture, point towards something systemic.
So what did they find on examination?
Well, her blood pressure was up 140 over 60. Her resting heart rate was fast, 100 beats per minute. That's tachycardia. And her breathing was a bit quicker, too. 17 breaths per minute tachypnea. Then there were some really noticeable physical signs. Her left eye was bulging out.
Bulging?
Yeah, the term is proptosis or exophthalmos. And in her neck, low down, there was this enlarged, smooth structure. Painless. It moved when she swallowed.
The thyroid gland.
Likely, yes. And when they listened with a stethoscope over it, they heard a bruit.
A brute, like a whooshing sound.
Exactly, a swishing noise with each heartbeat. It tells you there's a lot of blood flowing through there. Plus, her reflexes were hyperactive, and her hands had this fine tremor.
Okay, so a whole constellation of signs. What did the lab work show? That must have been key.
Very key. Her lab showed really high levels of thyroxine, T4, both total and the free active form. But her thyroid-stimulating hormone, TSH, was incredibly low. Suppressed, really.
High thyroid hormone, low TSH.
Correct. And her mid-cycle estrogen was low, too, which connects to the menstrual issues.
So putting it all together, what's the diagnosis?
It points clearly to hypothyroidism, an overactive thyroid, sometimes called thyrotoxicosis.
Okay.
The enlarged thyroid gland itself, that's a goiter. And the specific cause here, it's Graves' disease.
Graves' disease. That's autoimmune, right?
Exactly. It's an autoimmune disorder.
Yeah.
Her body is making these antibodies, thyroid-stimulating immunoglobulins, or TSIs.
TSIs.
Right. And these TSIs, they basically trick the thyroid gland. They bind to the TSH receptors and just keep telling the thyroid to make more hormone, T4 and T3, constantly.
So it's like the on switch is stuck, independent of the normal controls.
Precisely. It's running rogue. And because there's so much T4 and T3 circulating, the normal negative feedback kicks in, telling the pituitary gland to stop making TSH. That's why her TSH level was so low.
Ah, okay. That negative feedback loop. It's a perfect example of that integration you mentioned. So how does this one problem, this overactive thyroid, explain all those symptoms? The heat, the weight loss, the nervousness?
It connects really well. Thyroid hormone, you can think of it as setting the body's metabolic rate, the basal metabolic rate, or BMR.
Like the body's furnace?
Yeah, that's a good way to put it. It has a calorogenic effect. So high thyroid hormone means a high BMR. That explains the warm, moist skin, the heat intolerance, and the weight loss despite eating more. She's just burning through fuel much faster.
Okay, that makes sense.
The nervousness, irritability, mood swings, those are effects on the central nervous system. Plus, thyroid hormone makes the body more sensitive to catecholamines like adrenaline.
Ah, the fight or flight hormones?
Right, the muscle weakness. Probably from increased breakdown of muscle protein.
Yeah.
And the faster muscle contraction and relaxation speed. That links to the hyperactive reflexes in the hand tremors.
Got it. And the goiter and the brute.
The goiter is just the thyroid growing bigger because the TSIs are constantly stimulating it. And the brute, that swishing sound, is simply from the huge increase in blood flow to that very active gland.
What about the heart stuff? The high blood pressure, fast heart rate, and the menstrual problems?
The high systolic pressure and the tachycardia are direct effects of thyroid hormones on the heart muscle itself, plus that increased sensitivity to catecholamines we mentioned.
Right.
The diastolic pressure being a bit lower, the 60 and her 4-Kd60 reading, that's likely from arterial or vasodilation, the small arteries relaxing a bit in the skin and tissues to try and dissipate some of that extra heat.
Okay.
Her irregular periods and low estrogen. Well, high levels of thyroid hormone can actually interfere with the pituitary's release of gonadotropins FSH and LH, which are essential for the normal menstrual cycle.
Wow. It really does affect everything. What about the bulging eyes, the proptosis? Is that the thyroid hormone too?
That's actually a bit different. The proptosis isn't caused directly by the thyroid hormone levels. It's part of the autoimmune process of Graves' disease itself. White blood cells infiltrate the muscles behind the eyes, causing inflammation and swelling, and that pushes the eyeballs forward.
Fascinating. So it's linked to the underlying cause, not the hormone effect itself. So faced with all this, what's the treatment plan? How do you help her?
The main goal is to decrease the amount of thyroid hormone being produced or released. Several options. Surgery to remove the thyroid is one, but maybe less common now.
Okay.
More often, it's drugs like methimazole or pociluricin. These actually block the synthesis of the hormones within the thyroid gland.
They stop the factory.
Pretty much, yeah.
Oh.
They interfere with a key step called organification. Another really effective method is using radioactive iodine. She'd take it orally. The thyroid gland naturally traps iodine, so it concentrates the radioactivity right there, locally destroying the overactive thyroid tissue.
Clever. Targeted destruction.
It is. And for managing those immediate uncomfortable symptoms, the palpitations, the racing heart, nervousness, tremors, beta-adrenergic receptor blockers are very helpful. They counteract the effects of those catecholamines.
Ah, so symptom relief while the main treatment works.
Exactly. And for the proptosis, the eye issue, sometimes anti-inflammatory drugs like glucocorticoids are needed, or even in more severe cases, surgery or radiation therapy focused on the eye sockets.
That case really drives home how one system going haywire can ripple through the whole body. Incredible example of that physiological integration. Okay, shifting gears now. Our next deep dive is quite different. We have a 50-year-old man. He's obese, and he's just got off an 8-hour flight. Didn't really move much from his seat the whole time.
Long flight, sedentary.
Okay. Suddenly, he's in a taxi on the way home, and bam! Chest pain, shortness of breath, feels nauseous, breathing fast. He thinks it's a heart attack.
Understandable reaction with those symptoms. Scary stuff.
So he gets to the emergency department. His heart rate is up, 105 beats per minute. But, and this is crucial, his ECG, normal. No sign of a heart attack. Chest x-ray, also normal.
Okay, so chest pain, shortness of breath, but the usual cardiac suspects are negative.
Yeah.
It definitely makes you think differently.
Exactly. So they do arterial blood gases, and the results are pretty striking. His arterial PO2, the oxygen level, is very low, 60 millibule Hg.
That's quite hypoxic.
Right, hypoxia. But his PCO2, carbon dioxide, is also low at 30 millimillig, and his pH is high, 7.5 euro. Hemoglobin is normal, though.
Low oxygen, low CO2, high pH. So he's breathing fast, blowing off CO2, leading to respiratory alkalosis, but he's still hypoxic.
And here's another strange thing. They give him 100% oxygen to breathe.
You'd expect his PO2 to shoot way up.
Right, but it only goes up modestly, to 205 millimilli Hg. And the PCO2 and pH barely change. It's not the response you'd normally see. So low oxygen that doesn't fully correct with supplemental O2, low CO2, high pH, history of a long flight, obesity. What are the doctors thinking now?
With that picture, especially the travel history and the poor response to oxygen, the top suspicion has to be a pulmonary embolism.
A blood clot in the lungs.
Exactly. A blockage in the pulmonary arteries, usually from a clot, a thrombus that formed somewhere else, typically the deep veins of the legs, and traveled to the lungs.
Okay, how did they confirm it?
They did a ventilation perfusion scan, often called a VQ scan. The ventilation part showing air getting into the lungs was normal, but the perfusion part showing blood flow, that showed big areas with dramatically decreased blood flow, mismatched defects.
In, but no blood flow.
Precisely. And then an ultrasound of his legs confirmed it. He had a deep vein thrombosis, DVT, in his right leg. That was the source.
Wow. So the long flight, sitting still, that's the connection.
It's a major risk factor. When you sit for a long time without moving your legs, blood tends to pool in the lower veins. The skeletal muscle pump, your calf muscle squeezing the veins when you walk, isn't active.
Right.
That stagnant blood is much more likely to clot. His obesity was another risk factor. It can impede venous return and also affect clotting factors in the blood.
So multiple factors lining up.
And there was one more piece. He was actually found to have an inherited condition called activated protein C resistance. It's a genetic thing that makes his blood more prone to clotting hypercoagulability.
So a perfect storm, really. Immobility, obesity, and an underlying clotting disorder.
Exactly. The clot forms in the leg vein, breaks off, travels up through the bloodstream through the right side of the heart, and gets lodged in the pulmonary arteries, blocking blood flow.
Okay, that explains the clot. But how does that blockage cause those specific blood gas changes? The low O2, low CO2.
Right, let's connect that physiologically. The embolism creates what we call a ventilation perfusion inequality, or VQ mismatch.
VQ mismatch.
Yeah. You have parts of the lung that are getting air, ventilation, but no blood flow perfusion because of the blockage. This area acts like alveolar dead space. Air goes in and out, but no gas exchange happens.
Waste of ventilation.
Exactly. So the blood that can get through the lungs has to be diverted to the remaining unblocked areas. This can overwhelm those areas, leading to regions where blood flow is high relative to ventilation. This effectively acts like a physiological shunt, meaning some deoxygenated blood passes through the lungs without getting fully oxygenated and mixes back into the arterial circulation. That's why his overall arterial PO2 is low, hypoxemia.
Okay, that explains the low oxygen. Why the low CO2 and high pH?
That's driven by the hypoxemia itself, and also probably by the pain and anxiety from the chest pain. These signals stimulate their respiratory centers in the brain, causing him to hyperventilate.
Breathe faster and deeper.
Right, and hyperventilation blows off CO2 very effectively. So his PCO2 drops, and when CO2 drops, the blood becomes less acidic, so the pH rises. That's the acute respiratory alkalosis.
And why doesn't the 100% oxygen fix the low O2 completely?
Because of that VQ mismatch and shunt. The blood flowing through the well-ventilated areas is already nearly saturated with oxygen on room air. Giving more oxygen doesn't add much content because hemoglobin is already full. But you can't get oxygen at all to the blood flowing through the shunted areas or past the dead space. CO2 removal, however, is more directly related to ventilation levels, so hyperventilation still lowers PCO2 even if O2 uptake is limited.
Makes sense. And the chest pain itself, what causes that in a PE?
The exact mechanism isn't always crystal clear, but a likely cause is the sudden increase in pressure in the pulmonary artery because the clots are obstructing flow. The heart is straining against that blockage.
So how do you treat something this immediately dangerous?
Urgently. He needs anticoagulation right away, usually with intravenous heparin, to prevent new clots from forming and existing ones from getting bigger.
Okay.
And often, especially if it's a large embolism causing instability, they'll use recombinant tissue plasminogen activator, or REC-TPA. That's a clot-busting drug designed to dissolve the existing emboli.
Thrombolysis.
Exactly. Supplemental oxygen is also vital, of course, and long-term. Because he has that underlying activated protein C resistance, he'll likely need to be on anticoagulation therapy indefinitely. Plus, lifestyle changes, weight loss, avoiding prolonged immobility become really important.
Another stark reminder of how interconnected things are. A leg clot causing a lung crisis. Okay, let's move to our third deep dive. This one starts in the wilderness. A 21-year-old college student canoeing in Alaska.
Remote setting, okay.
He starts feeling pain in his abdomen, gets the shivers, feels intensely cold even though it's apparently a warm day, and his symptoms just get worse and worse over the next 36 hours.
Not good, especially being remote.
By the time he finally makes it to an emergency department, he's in bad shape, confused, drifting in and out of consciousness.
Altered mental status, serious sign.
His temperature is high, 39.2 Celsius, that's 102.6 Fahrenheit. Heart rate is flying at 140, respiratory rate is 34, and his blood pressure is critically low, 84/44.
Tachycardic, tachypneic, febrile, hypotensive. It's shock.
His abdomen is rigid, very tender, especially the lower right side, and he hasn't passed urine in over a day. They put in a catheter, only get 10 millimills out.
With full agoria nearing anuria. Kidneys aren't working.
Okay, critical picture. What did the initial labs show?
White blood cell count was sky high, 25,000, huge sign of infection.
Right.
Arterial blood gases. PO2 was okay, but PCO2 was low at 28. pH was low at 7.25. Bicarbonate was low at 13.
Yeah.
And his lactate level was really high, 8.0.
Low pH, low bicarb, high lactate. That's metabolic acidosis, specifically lactic acidosis. And the low PCO2 shows he's hyperventilating, trying to compensate.
Exactly. Metabolic acidosis with respiratory compensation. And his creatinine was high too, 2.2, confirming the kidney injury.
So, abdominal pain starting in the wilderness, leading to fever, shock, acidosis, kidney failure. What ties this all together?
The diagnosis was severe appendicitis that had ruptured and progressed to septic shock.
Appendicitis.
Yes.
Oh,
A CT scan confirmed an inflamed perforated appendix. When they took him to surgery urgently, they found exactly that. A ruptured appendix with necrosis, dead tissue, and infection spread throughout the abdominal cavity peritonitis. Lots of pus had to be removed and the area cleaned out.
it's incredible how something that seems relatively common, like appendicitis, can spiral into, well, this life-threatening condition.
Mm.
How does that happen? How does it cause shock?
It's a really important question about the body's response.
Yeah.
Usually the appendix gets blocked, maybe by stool or inflammation. Bacteria normally present in the gut then multiply like crazy inside the blocked appendix.
Okay.
This leads to inflammation, swelling, pressure buildup, impaired blood flow, tissue death, necrosis, and eventually perforation or rupture.
So it bursts.
Right. And that releases bacteria and their toxins directly into the peritoneal cavity, the space surrounding the abdominal organs. This triggers a massive inflammatory response.
Okay. Inflammation makes sense. But the shock, the low blood pressure.
That's where sepsis comes in. Sepsis is defined as having an infection plus signs of a systemic inflammatory response fever, high heart rate, high respiratory rate, high white blood cells. He had all of those.
Right.
When sepsis gets so severe that it causes profound, persistent low blood pressure despite giving fluids, that's septic shock. It's a form of low-resistance shock.
Low resistance, meaning the blood vessels are too dilated.
Exactly. It seems counterintuitive, right? You have a massive infection, but the blood pressure plummets. It's because the bacterial toxins trigger an overwhelming release of inflammatory mediators, especially cytokines, from immune cells like macrophages.
Cytokines. I've heard of cytokine storms.
Sort of
Yeah.
related, yeah. These cytokines have widespread effects. They act on the brain, causing fever and fatigue. They stimulate the bone marrow to pump out more white cells. But critically, they act on the endothelial cells, the lining of blood vessels all over the body.
And what do they do to the blood vessels?
They cause widespread inflammation and make the capillaries incredibly leaky. Increased capillary permeability.
Leaky capillaries.
Yes. Plasma proteins, which normally stay inside the blood vessels and help hold fluid in, start leaking out into the tissues, into the interstitial fluid. And water follows protein because of osmotic pressure starling forces.
So fluid leaves the bloodstream and goes into the tissues.
Precisely. You get a massive shift of fluid out of the circulation. Blood volume plummets, leading to severe hypotension, the low blood pressure, and all that fluid accumulating in the tissues causes widespread edema or swelling. This can even happen in the lungs, causing pulmonary edema, which makes breathing even harder.
Wow. So the body's attempt to fight the infection actually causes the circulatory collapse. That explains the low blood pressure and maybe the swelling. What about the kidney failure and the lactic acidosis?
That follows directly from the low blood pressure and poor circulation. When blood pressure is that low, blood flow, perfusion to vital organs is severely reduced. That's ischemia.
Not enough blood flow.
Right. The kidneys are very sensitive to this. Low blood flow means a drastically reduced glomerular filtration rate. They can't filter waste or make urine effectively. That's why his urine output was almost zero and his creatinine was high.
Okay.
And when tissues don't get enough oxygen because of the poor blood flow, the cells can't perform normal aerobic metabolism. They're forced to switch to anaerobic pathways to generate energy.
Which produces lactic acid as a byproduct.
Exactly.
Yeah.
Massive amounts of lactic acid buildup, overwhelming the body's buffering systems and causing the severe metabolic acidosis. His hyperventilation was the lungs trying desperately to compensate by blowing off CO2 acid, but the kidneys, which normally help by excreting acid and making bicarbonate, were failing because of the poor blood flow.
What a devastating cascade. How do you even begin to treat someone in septic shock? It sounds incredibly complex and dangerous.
It is. Septic shock has a high mortality rate, so time is absolutely critical. Early recognition, rapid treatment, constant reassessment. The absolute priority is restoring oxygen delivery to the tissues.
How?
First, aggressive fluid resuscitation with intravenous isotonic saline to try and refill the circulatory volume lost to the leaky capillaries. Often, huge volumes are needed.
Okay, fluids first.
But often fluids alone aren't enough because the vasodilation is so profound. So vasopressors are usually required. Drugs like norepinephrine or vasopressin are given intravenously to constrict blood vessels, raise blood pressure, and improve cardiac output and tissue perfusion.
Squeeze the pipes.
Essentially, yes. Supporting breathing is also key, supplemental oxygen, maybe even mechanical ventilation, to reduce the work of breathing, which itself consumes a lot of oxygen.
Makes sense.
And, crucially, you have to treat the underlying infection. Broad-spectrum antibiotics are started immediately, even before the exact bacteria are identified. Then, find the source, in his case, the appendix, surgically remove the infected tissue, like the dead appendix, drain any pus, and clean the area thoroughly. Source control is vital.
So fluids, pressors, oxygen, antibiotics, and surgery. A multi-pronged attack.
Absolutely. Sometimes, in very severe cases, high doses of glucocorticoids might be considered for their anti-inflammatory effects and to potentially improve the blood vessel's responsiveness to the vasopressors. It's a complex, dynamic, and very challenging condition to manage.
Okay, one final case study for this deep dive. This involves a 21-year-old female college student. She starts having these episodes. Yeah. She feels nausea, gets flushed, starts sweating, and then feels this tingling or jerking sensation. It starts on the left side of her face, then seems to travel down her left arm and left leg, lasts a few minutes each time, and it's not related to alcohol or anything obvious.
Very specific neurological symptoms. Focal onset, marching down one side. Okay.
While she's waiting for an ambulance for one of these, she has a much bigger event. Loses consciousness, starts having rhythmic convulsions of both arms and legs.
A generalized seizure.
Looks like it, yeah, like an epileptic seizure. Her back arches, eyes roll back. They had a transcutaneous oxygen monitor on her, and her O2 saturation dropped to 83% during the convulsions.
Significant desaturation. Hypoxia during the seizure.
After the shaking stops, she doesn't wake up right away, and she urinates involuntarily.
Postictal state with incontinence. Classic seizure features.
In the ER, her blood pressure and heart rate are both up. Temperature's normal, though. Blood tests, electrolytes, white cells, hematocrit, creatinine, all normal. Her blood glucose is a little high, 130. But neurologically, they notice she has decreased motion and brisker reflexes on her left side.
Okay, so elevated vitals, likely from the seizure stress, normal basic labs ruling out some common metabolic causes, but persistent focal neurological signs on the left side even after the seizure.
So what could cause recurrent seizures with that specific left-sided pattern and those residual signs?
The focal nature points strongly towards a problem in a specific area of the brain. An MRI scan of her head was done. It revealed a lesion, about 2 centimeters in size, located in the right temporal lobe of her brain.
A lesion on the right side.
Yes, they needed to figure out what it was. After ruling out things like an infection or abscess, she underwent a craniotomy surgery to open the skull for a biopsy.
And the biopsy showed.
Unfortunately, it showed a glioblastoma multiforme.
Glioblastoma, that's a brain tumor, right? A bad one.
Yes, it's a highly malignant type of brain tumor, a neoplasm. It arises from brain support cells called astrocytes, so it's a type of astrocytoma. Very aggressive.
Okay, so a tumor in the right temporal lobe. How does that explain the symptoms, starting on her left face and moving down her left arm and leg?
This goes back to that fundamental principle of brain organization we touched on earlier, contralateral control.
Right, the brain's wiring crossing over.
Exactly. The motor pathways controlling movement, originating in the cerebral cortex, cross from one side of the brain to control the muscles on the opposite side of the body. So irritation or damage from a tumor in the right temporal lobe would absolutely cause neurological symptoms like the tingling, jerking, seizures, and weakness, primarily on the left side.
That makes perfect sense. What about the brisker reflexes on the left?
That's also related to damage in the right cortex. Normally, the brain sends down inhibitory signals to the spinal cord motor neurons, keeping reflexes in check. This is descending inhibition.
Like putting the brakes on reflexes.
Kind of, yeah. When the right cortex is damaged by the tumor, it loses that inhibitory control over the left side of the spinal cord. Without those braking signals, the reflexes on the left side become uninhibited or brisk.
Okay, got it. And the other symptoms during the big seizure, the flushing, sweating, high heart rate, low oxygen, losing consciousness.
The tumor itself acts as an irritant to the surrounding brain tissue, triggering the abnormal electrical discharges that cause the seizures. During a major seizure like that, there's a massive surge of sympathetic nervous system activity.
Fight or flight again?
Big time. That explains the nausea, the flushing, the sweating, the spike in blood pressure and heart rate. The low oxygen saturation, hypoxia, happened because the intense, rigid muscle contractions during the seizure included her respiratory muscles. She basically stopped breathing, effectively hypoventilation.
Ah, okay.
The loss of consciousness is part of the seizure's effect on overall brain function, and the urination afterwards. Once the huge sympathetic surge ends, the underlying parasympathetic tone can rebound or become dominant, sometimes leading to involuntary micturition.
Did they think about other things that could cause seizures before landing on the tumor?
Oh, definitely. You always consider other possibilities.
Yeah.
But our normal electrolytes ruled out major ion imbalances affecting nerve function. Normal creatinine meant her kidneys were working, ruling out severe metabolic issues like uremic encephalopathy.
What about blood sugar? Can low blood sugar cause seizures?
Yes, severe hypoglycemia can. But her glucose was actually slightly elevated, probably due to the stress response from the seizure, so that wasn't it. And the MRI also confirmed she didn't have hydrocephalus excess fluid buildup, causing pressure in the brain ventricles, which can sometimes present with convulsions. The MRI finding of the distinct lesion was really the key.
So given this is such an aggressive tumor, glioblastoma, what's the treatment approach?
It's challenging, requires a multimodal approach.
Yeah.
Typically involves surgery to remove as much of the tumor as safely possible.
The bu-
Right. Followed by radiation therapy to the area, and then multiple rounds of chemotherapy to try and kill remaining cancer cells. To manage the seizures, she'd be put on anti-epileptic drugs, like phenytoin, brand name Delanton. Phenytoin works by blocking certain sodium channels in neurons that are firing too rapidly, helping to prevent seizures.
Stabilizing the brain's electrical activity.
Exactly. And high doses of synthetic glucocorticoids are almost always used too, especially around the time of surgery or radiation. They're powerful anti-inflammatories and also reduce edema swelling in the brain tissue surrounding the tumor, which can help alleviate symptoms caused by pressure.
So surgery, radiation, chemo, anti-seizure meds, steroids, a full court press.
It has to be. Unfortunately, despite all that, glioblastoma multiforme remains a very difficult cancer to cure. While this patient's initial symptoms resolved after treatment, the long-term prognosis is often challenging.
Wow. Wow. What an incredible tour through these cases. We've seen hyperthyroidism, essentially turning up the body's thermostat due to an autoimmune attack. We saw how prolonged sitting could lead to a DVT and then a life-threatening pulmonary embolism.
Mm-hmm.
We saw the terrifyingly rapid progression from appendicitis to systemic collapse and septic shock, driven by the body's own inflammatory response.
A response gone wrong.
And finally, how a brain tumor, a glioblastoma, can cause such specific, localized neurological deficits and seizures because of the brain's precise functional map.
And if you connect it all back, what really stands out, I think, is just how deeply interconnected everything is. Integrative physiology in action, or sometimes inaction. These cases aren't just interesting stories. They highlight why understanding these mechanisms is so fundamental.
It's not just academic.
Not at all. It's the foundation for diagnosis, for treatment. It allows clinicians to take all these different pieces, symptoms, signs, lab results, and put them together into a coherent picture. It really shows the body's resilience, but also its vulnerability when key systems are disrupted.
Absolutely. And for you listening, we really hope this deep dive hasn't just given you a shortcut to understanding these conditions, but maybe also a renewed appreciation for just how complex and integrated our bodies are.
Mm-hmm.
Think about these stories. How do these principles, feedback, compensation, systemic effects apply elsewhere? What other questions does this spark for you about how the body works?
Yeah, keep exploring those connections. And with that, from everyone here at the Deep Dive and the whole Last Minute Lecture team, thanks for joining us. We hope you feel a bit more informed, maybe a bit more prepared, and definitely more curious about the amazing world of human physiology.